Dr. Pragati ma'am, over to you. You can start your case presentation. Thank you.
Today I am presenting a case on Guillain-Barré syndrome. So, a 29-year-old female, Shweta Wagmare, of resident of Belapur, Navi Mumbai, primary school teacher by occupation, uh, came with a chief complaint of weakness of all four limbs since 3 days. The patient was apparently all right 10 days back when she developed fever and malaise. The fever was continuous in nature and it subsided on the next day after taking medication from a local practitioner. The fever was accompanied by a runny nose, sore throat, and dry cough, which subsided after 2 days of taking medication from a local practitioner. After this, the patient was asymptomatic for next 4 days, after which the patient experienced heaviness of both the legs while walking and difficulty in lifting the leg from ground during walking in the evening. It was then followed by inability to wear footwear such that she was unable to insert her toes inside and grab the chappals. In the night, the patient experienced weakness of both the upper limbs when she was unable to twist the key to open the lock, when she previously used to do without any effort. Next morning, the patient was unable to comb her hair when she had difficulty in raising the comb above her shoulder. She was able to hold the glass water and break morsels of breakfast and lunch. Later in the evening during dinner, she was unable to hold a glass of water or break chapati with her hand. The next morning, the patient was unable to even get up from the bed, unable to dress herself, unable to squat or get up from the squatting position. She was unable to lift both her legs from the ground while walking, and therefore she took very small step with minimum lifting of feet with maximum effort and moving the weight of her body on either side. There was no history of fall, trauma to spine, or any heavy weight lifting. There was no history of loose stools or vomiting. There was no history of loss of consciousness, altered sensorium, or involuntary limb movements. There was no history of headache, stiffness, projectile vomiting. There was no history of diurnal variation, ptosis, or diplopia. There was no history of hyperesthesia, paresthesia, or tingling numbness. There was no history of any consumption of any alternative medicine. On general examination, patient was conscious, oriented to time, place, and person. The weight was 52 kg and the height of 152 centimeter, giving a BMI of 22. The pulse was 80 beats per minute, regular, normal in volume, and equal on measuring both the arms. The BP was 120 by 60 mm of Hg in standing as well as supine position. The saturation was 96% on the room air. Respiratory rate was 16 per minute. There was no neurocutaneous markers or rashes. There was no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. On systemic examination, the patient is conscious, oriented to time, place, and person. She was right-handed. The speech memory intelligence was normal. The cranial nerve examination was unaltered. On motor examination, the patient left shoulder and elbow are in flexion, and hip and knee joint was in extension. The bulk of both the right and the left arm were measured. In the arm, it was 25 centimeter, both right and left. Forearm, there was 19 centimeter in both right and left. Thigh, it was 50 centimeter, both right and left. And in the leg, it was 29 centimeter in the right, and left, it was 30 centimeter. There was no mixed wasting observed. In the power of the right hand, right as well as left, were measured on shoulder, elbow, wrist, hip, and knee, ankle, and all were 4 by 5. The superficial reflexes were checked. Abdominal and corneal reflexes were present. On deep tendon reflexes, bicep, tricep, and knee, both right and left deep tendon reflexes were present, whereas in the ankle, both right and left, it was absent. On the plantar reflex were bilateral flex. Sensory examination, the touch, pressure, vibration, pain, and temperature all were normal in all the four limbs. The meningeal signs were absent. Cerebral signs were not elicitable. All other systemic examination like cardiovascular, S1, S2 were heard. In a respiratory examination, air entry was bilaterally equal, wherein the abdomen was soft and non-tender. Based on the basis of the history and examination, the probable diagnosis was acute onset of flaccid quadriparesis of element type without sensory or autonomic involvement, probably due to axonal or maybe demyelinating polyneuropathy with possible etiology of GBS, Guillain-Barré syndrome.
Hello, Dr. Pragati. I am Dr. Payel Bose over here. So, have you completed the presentation of your case?
So, as the definition goes, the Guillain-Barré syndrome is an acute onset
So Pragati,
polyneuropathy.
please wait. Dr. Payal ma'am was asking something.
Yes, ma'am.
Yeah,
Payal
yeah,
ma'am,
Yes.
Dr. Srikanth, thank you. Dr. Pragati, it's Dr. Payal Bose here. So, I believe that you were supposed to present the case, and after that, you were supposed to take questions
Okay.
from us.
Yes, yes,
Fatma,
ma'am.
is that so?
Yes,
Yes, ma'am.
ma'am.
So it's an examination, right? Based
Yes,
upon your
Yes, ma'am.
case, we are going
Yes.
to cross you,
yes,
and it's not a presentation of the GB syndrome in totality. Dr.
yes.
Srikanth, is that so?
I think so, ma'am.
Yeah. So,
Okay.
Pragati, if your case is over, then I think it would be better if you start taking questions from the examiners.
Yes, ma'am. Yes, ma'am.
Okay. So, is your case over, Pragati?
Yes,
Or do
ma'am.
you have anything to tell more about the case? What happened? The case got admitted. You did something. So, do you have any more further details of the case available with you?
Yes, ma'am. Ma'am, she got admitted with us. She was admitted on the
So, are
day.
there slides pertaining to her course of admission, Dr. Pragati?
No, no, ma'am. No.
Okay. So, regarding this particular case, you have this much slides only. Am I
Yes, ma'am.
right?
Yes, ma'am.
Okay, fine. So then, from her clinical assessments, you
Yes,
have reached upon the probable diagnosis, which is mentioned in this slide, right? So,
yes, ma'am.
yeah. So, Dr. Srikanth, would you like to start questioning her?
Yes, ma'am. Okay, thank you, ma'am.
Okay.
Dr.
Thank you.
Pragati,
Yeah. Hmm.
and just like when we simply start daily during our ICU rounds, also in our exams, after this, just when you complete your case presentation, we just start with some basics. So we'll start up with some basics, then we'll proceed with the case. To start with, just summarize your case. Just summarize your case in a few lines.
Uh, so
Can you
his,
please summarize?
yes, sir.
Yes, please. Slides are not
So
required, just summarize in few lines.
yes, sir. She is a 29-year female. She complains of weakness of all four limbs, with a history of upper respiratory tract infection. She had fever and all. For Subsequently, she developed all the four limb weakness, which was affecting her day-to-day life, and it was rapidly progressive, and she didn't have any history of trauma, and
Anything to add?
mm,
Okay.
it was
See,
more of a
okay, tell me. Please
yeah,
continue.
it was more of a lower motor neuron type of presentation, and she didn't have any history of trauma, and she didn't have any GI complaints also. Only she had a history of URTI, after which she developed a weakness.
Are you completed?
Yes, yes,
They are completed, I will add something. Okay.
yes,
So basically, when we summarize a case, we start with basics like 29-year female, presented with all four limbs weakness for 3 days. And when we summarize your case, apart from this, you have to give the three information. One is demographic, second is a chief complaint and history of present illness. Third is also your what you find in your examinations. So these three things should be summarized in few lines so that the examiner will get a clue what is the things, what are the diagnosis, or what is the system, or what disease you are going to present. So in your case, basically the young female, a school teacher by occupation, and presented with all four limbs weakness 3 days, and there is a prior history of features of upper respiratory tract infection. And this upper respiratory, there is upper features of upper respiratory tract infection followed by the quadriparesis. And you did not mention about, clearly did not mention about the gap and how rapidly the disease progressed, how it started and how rapidly it progressed. And Also, you have to mention the present findings because you have already completed the case. So you have to say also the regarding the examination findings. This is the power of this. There is quadriparesis. This is the power of all four limbs or whatever. There is proximal weakness or distal weakness. There is neuropathy or myopathy because there is only in chief complaint there is only weakness of all four limbs and there is a prodromal features of upper respiratory tract infection. But from this history were not clear whether the patient is having myopathy or having neuropathy or what and what is the rapidity of the progression. And also as you have completed the examination also you have to add the examination finding and that is only positive findings and significant also you can add the significant negative findings there as there is no history of a trauma, there no history of any recent vaccination. These are the important findings. Dr. Payal
Yes.
madam and Ankur sir, you can add please.
Okay, so Dr. Pragati, what are the main differential diagnoses which you will consider in this case?
Ma'am, I will consider for myasthenia gravis. Then, ma'am, any periodic paralysis, any tick paralysis or selfish poisoning, or critical illness, neuropathy or myopathy, botulism. And, sorry, ma'am. Hello.
Yeah, please proceed.
There may be uh, porphyria or even OPP poisoning.
You
Mm,
mean organophosphorus?
yes, ma'am. And ma'am, if firstly, ma'am, we have to delineate if it is an upper motor paralysis or lower motor, and if then if there is any transverse myelitis. And
Okay, so Dr. Pragati, you have stated out certain of the points very saliently, but you see, you need to include it in a fashion that you do not miss out any. Like when you consider this is a case of acute flaccid paralysis, right?
yes.
So, when you consider the case, and also you have to make a note regarding the differential diagnosis, please proceed system wise. Like you start with brainstem, stroke, or
Okay.
encephalitis. Then acute anterior poliomyelitis might be there, or any acute myelopathy. In myelopathy, you include acute transverse myelitis or any SOL or tumors, right? Then
Okay.
you come to the broad heading of peripheral neuropathy, then disorders of neuromuscular transmission, then the muscle related disorders. So, if you go on proceed systematically, you will be much more in a better position. Okay. So, Pragati, from the clinical assessment, you have mentioned about that this might be a case of GB syndrome. So, what are the causes which might have led to this GB syndrome?
Ma'am, there are various trigger factors
Okay.
which can land the patient in GB syndrome. Like she had a history of upper respiratory tract infection, so
Mm-hmm.
mycoplasma pneumonia or Haemophilus influenza, and sometimes even GI tract infection such as Campylobacter jejuni, and even
Okay.
hepatitis E, A virus, influenza virus, Zika virus, and history of vaccination, COVID-19 virus have been the trigger factors which has led to in like a molecular mimicry which can lead to initiation of GB syndrome in a patient.
Okay. So, what are the diagnostic criteria for GB syndrome?
Ma'am, we use Brighton criteria for diagnosis of GB syndrome, which involves about 6 parameters and about in which there is the level of diagnosis level 1, 2, and 3. In Brighton diagnostic, we consider 6 parameters such as symmetric flaccid limb weakness, lack of absent deep tendon reflex, the GBS have monophasic course and which appears about within 12 to 28 days of appearance. Then the CSF, if the cell count is less than 50 micron per liter, and the protein, the CSF protein concentration. sorry, and the if the nerve conduction study are consistent with GBS or lack of any alternative diagnosis
Dr.
for.
Pragati, I am interrupting you a little bit. You mentioned about the CSF report, right?
Yes, ma'am. Yes, ma'am.
So can you elaborate a little bit on the CSF results, which will guide you towards the diagnosis of GB syndrome?
Yes, ma'am. Ma'am, in GB syndrome, there is an typical albino-cytological dissociation in which there will be increase in the cell count, but the protein will be in the normal range. The there will be increased CSF protein as well as absence of in the absence of increased WBC.
Okay. So if the protein level was normal, so will you rule out GB syndrome?
No, GB syndrome is mainly a clinical diagnosis rather than depending only on the CSF analysis.
No, you mentioned about albuminocytologic dissociation of CSF to diagnose the case of GB syndrome. Agreed. Now,
Hmm.
if the protein level was normal,
Hmm.
but the clinical findings are pointing out towards GB syndrome, right?
Yes, ma'am.
So, will you rule out GB syndrome based upon the CSF normal protein levels?
No, ma'am.
So,
Ma'am,
what is your interpretation?
ma'am, I will go for nerve conduction studies.
No, that is fine. Okay, Dr. Pragati, I shall tell you the answer. Huh?
Yes,
So,
ma'am.
in GB syndrome, CSF result may show that the protein level is normal. Okay?
Hmm.
Because in the early part or initial part after onset of GB syndrome or acute inflammatory demyelinating polyneuropathy, protein level may or may not rise, particularly in the first week. Okay? So, that is why comes the importance of the diagnostic modalities of GB syndrome. Okay, right.
Yes,
In the diagnostic criteria that you were mentioning, you had also uttered the same thing, right?
yes,
Okay.
ma'am.
So now, have you heard of Miller-Fisher syndrome?
Yes, ma'am. Miller fascial variant of GBS. Yes, ma'am.
Yeah.
Uh,
So yes. So what
it
happens in Miller-Fisher syndrome?
it is a ma'am, triad of areflexia with ophthalmoplegia and areflexia with sometimes overlap with GB syndrome.
So can you please tell again? Tell us again.
Ma'am, it is a triad of ophthalmoplegia, ataxia, as well as areflexia.
Okay.
Sometime it may present with weakness of limbs, so there will be an
As
overlap of
well.
GB syndrome as well as
Right. Right. Okay. So, what are the respiratory and neurological manifestations of GB syndrome?
Ma'am, firstly, there will be firstly sensory involvement. Patient may have uh, tingling sensation of limbs of tip of the fingers and the toes, and the sensation may be intact. In the motor paralysis, there will be an ascending flaccid symmetrical paralysis involving more of the proximal and then the distal involvement. There will be autonomic dysfunction as well as um, autonomic dysfunction and
Concealed by did not disclose.
sometimes there will be cranial nerve involvement as well. Sometimes facial nerve and ocular nerve may also be involved, and in the respiratory, as the if the bulbar involvement is there, the patient will not be able to swallow, and there will be dysphagia, which eventually lead to will land the patient in respiratory failure. So it is important that we do a everyday bedside pulmonary function test so that we get to know the respiratory reserve of the patient, and we can make the decision regarding intubation.
Okay. So, Dr. Pragati, can you elaborate about the dysautonomia in GB syndrome? What happens? What are the manifestations of dysautonomia in GB syndrome?
Yes, ma'am. The patient may have the blood pressure may be extremely labile, and the patient may have abdominal pain, ileus. There may be sympathetic activation causing hypertension, agitation, diaphoresis, tachycardia, or even the parasympathetic may be involved causing bradycardia, facial flushing, and vasodilation. Sometimes patient may have constipation, diarrhea, and urinary retention type symptoms.
Okay. And also features of orthostatic hypotension, right? There
Yes.
can be sympathetic as well as parasympathetic involvement, and a reduced amount of sweating, salivation, lacrimation, all this might be observed in cases of dysautonomias. So, Dr. Shrikant, any questions from your end?
Yes, yes, ma'am. Dr.
Yeah.
Pragati, can you please tell the how to classify the GBS? What are the very different types of GBS?
Yes, sir. So there are variants such as acute inflammatory demyelinating polyneuropathy, as well as acute motor axonal neuropathy. In acute motor axonal neuropathy, there will be AMSN and MR type. In AMSN, it will be acute motor and sensory axonal neuropathy, whereas in motor involvement, there is acute motor axonal neuropathy. And there are other types such as Miller-Fisher variant, then Bickerstaff brainstem encephalitis, pharyngeal cervical brachial variety.
Good. Can you please tell about the pathophysiology of the GBS? Pathophysiology.
Yes, sir. So mainly all the trigger factor which we have discussed earlier, the subtype upper respiratory tract infection or upper GI infection, all will lead to a event of molecular mimicry, and the Campylobacter jejuni have a lipo-oligosaccharide molecule which mimics the oligosaccharide found in our nerves in our found in our gangliocytes. So eventually, this molecular mimicry will trigger a complement activation and formation of molecular activation complexes. These molecular activation complex either will affect the myelin sheath or the axon. If the myelin sheath are affected, it will cause AIDP variant. If the axon are affected, then it will cause MAN or AMSON type of variant. And these complement activation will eventually cause nerve injury, and eventually the macrophage will invade the axon or the myelin sheath and cause the phagocytosis of the myelin debris.
Okay, good. Can you please tell the what are the indications of ICU admission in case of GBS? Indication of ICU admission, because all cases of GBS are not admitted to ICU.
Yes, sir.
Yes, please.
Sir, if the single breath count test is less than 20, and there is if there is pooling of secretion, or there is effect in if there is dysphagia, or if the patient is not able to swallow, or if the forced vital capacity is less than 20 ml per kg, or the maximum inspiratory pressure is less than 30 centimeter of water, and the maximum expiratory pressure is less than 40 centimeter of water, which is the 20-30-40 rule. And if there is a increase in the weakness, like rapid progression of the weakness, or if the PO2 value is less than 60 in room air, if the patient is
Basically, how would you decide the patient needs intubation at the bedside? What are the things theoretically you are saying? Usually, you do not measure at the bedside.
yes.
In bedside, how do you decide this patient will require mechanical intubation or mechanical ventilation? Because till the end, for the very advanced stage, there is no fall in SpO2 or there is no hypoxia in case of GBS.
So we can use Erasmus GBS respiratory insufficiency score to
Anything else clinically? Clinically, anything else? One is you told single breath count.
then, sir,
Yes. Anything else?
even match test, uh, Snyder match test can be put.
Yes. Anything else? Neck muscle weakness.
Yeah, neck
Unable
muscle
to.
weakness.
Yes. 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 Please.
Neck muscle
Neck
weakness,
muscle weakness.
proximal
Unable
weakness,
to lift
unable
the
to
head.
lift the head for more
Yes.
than 3 seconds.
Yes, anything else?
Tachypnea, and
Not
increase
thank you.
effort, increase in effort of this.
Just
Unable to live. Yes, yes,
interrupting.
ma'am, please. Yes, ma'am, please.
Thank you. Thank you. Thank you. So, Dr. Pragati, are you aware of a rule that is 20-30-40 rule in managing the patient of GBS and determining which patients of GBS would be requiring mechanical ventilation? 20-30-40 rule?
Yes, ma'am.
Yeah.
Yes.
Can you please elaborate?
Ma'am, 20-30-40 rule is if the forced vital capacity is less than 20 ml per kg, if the
Okay.
maximum inspiratory pressure is less than 30 centimeter of water, and if the
Okay.
maximum inspiratory pressure is less than 40 centimeter of water, it is an indication for intervention.
Okay. Okay, good. So, this 20-30-40 rule is a guideline and not a strict cutoff point, actually, right? So,
Yes, ma'am.
this overall depends on the clinical status of the patient, the severity, the time frame in which the weakness is developing, and also presence of certain other complications. And all these things taken together will actually help or guide us in deciding about the requirement of invasive mechanical ventilation. Thank you, Dr. Shrikant. You may please continue.
Pragati,
Okay, ma'am.
why is there albumocytological dissociation in GBS?
Sir, sir, as there is molecular mimicry with shared ganglioside antigen and between the peripheral nerve and pathogen, there will be an increased permeability of the blood-brain blood nerve barrier, which will cause increase in the protein of the CSF.
Right. The nerve-brain barrier is damaged because of removal of myelin debris. That's why protein seepage is there, which causes albumocytological dissociation.
Ankur sir, are you there? Ankur sir,
Yeah, I'm here.
Hello.
please,
Yeah.
sir, please. Yes, Ankur sir, please.
Thank you, Dr. Shrikant. So, well presented.
Sir, your voice is not audible enough.
Sir, please increase your audio.
Yeah, just so. So, am I audible now?
Yes, sir, better.
Yeah. So, she has very well presented, but from exam point of view, when she is supposed to present a long case, GBS will be asked to present as a long case. Then a detailed history has to be present. Of course, she has presented it, but she has presented it very concisely as a GBS. So it starts with demographics, starts with history of present illness. The way we present it in final exams, it's the same throughout the career, right? As a student, please remember it. History of present illness, then past illness, any comorbidities if the patient has, because it's a acute onset flaccid paralysis. I would have been interested in knowing if there is any recent onset of recent vaccination history, any recent drug history patient has taken, any history of travel, recent travel patient has undergone, family history, whether any other person in the family or any other relatives have undergone the same symptoms, just like the patient, history of bladder habits, bowel habits, and examination of all the systems. You started with neurology, you completed with neurology, but that is now not to be presented in exam, right? You may start with CNS, but then you have to give a detailed examination findings of respiratory system, cardiovascular system, abdominal system, musculoskeletal system, and autonomic symptoms, right?
Yes, yes,
Thereafter, you come to a certain provisional diagnosis after your clinic, after your history and clinical examination, right? You come to a
yes,
provisional diagnosis. Then
yes,
you need to present what are the investigations you did for this patient.
yes,
So then history, clinical examination, and investigations. Now, what is your final diagnosis? Initial was provisional diagnosis based on your history, clinical examination, and now after the investigations, you have to come to a final diagnosis. There, your case presentation will end. You got it, no?
yes,
And then you must have certain differential diagnosis, because then you will be asked what are the differential diagnoses of your cases. Then
yes,
how to exclude them one by one.
yes.
Do you think history taking of musculoskeletal examination is important in this case?
Yes, sir.
Why?
Sir, so that we can know any myopathy or neuropathy is there.
One of the that is okay. You will have depressed tendon reflexes, that's for sure.
Yes.
But then we come across so many, because I work exclusively in a neuro ICU. So muscle pain, have you gone through the literature? Muscle pain is very
Yes, sir.
common in Guillain-Barré syndrome, right?
Yes.
The patients will complain of muscle pain, particularly in the thighs and in the calf muscles.
Yes.
Clear?
Yes.
Do you think is there any relevance of bladder and bowel history taking in this patient?
Yes, sir.
Why?
Sir, the involvement will be in the later stage in GBS, whereas
Usually at the
it will
time of
help.
Mhm. Yes, please.
It will help us to differentiate from transverse myelitis and other differentials of GBS.
So usually if bladder and bowel symptoms are there at the time of presentation, it excludes the diagnosis, almost excludes the diagnosis of GBS. That is so important. Correct? There may
Yes.
be some symptoms of bladder and bowel in the later stages, but never at the time of presentation. That is an excluding point.
Yes.
What are the important things you would have taken in your history examinations in the autonomic system?
Sir, in autonomic systems, sir, heart rate, then blood pressure, uh, then respiratory rate, then any complaint of abdominal pain, diarrhea, constipation, ileus.
Okay, got it, got it. I think you also mentioned this one initially, right? So tell me some important findings that excludes GBS at the time of presentation. Some important findings. You got my question?
Yes, sir.
Say for example, I told you one thing, that bladder and bowel symptoms are usually not present at the time of presentation of the patient. Some other things which will exclude, which will help you in excluding GBS.
If the patient had critical illness for more than 2 weeks and then there is development of flaccid paralysis, then it is more towards critical illness, myopathy or neuropathy.
Okay.
Dr. Pragati, just interrupting. Basically, sir wants to know if you a patient presents with acute onset quadriparesis and you
Okay.
are thinking of it is a GBS, then what are the features if present in that patient? Then your diagnosis will go against GBS. That's what I think sir is asking.
Yeah, that's what.
Mm.
You got my point now? It is
Yes,
acute
sir.
onset quadriparesis, and you are thinking it is a GBS, but what are the points if present? Then you will think no, it is not a GBS.
Yes. Sir, if there is any symmetrical feature or hyperreflexia.
Okay, good. Hyperreflexia. Usually it's a peripheral nerve disorder. So you don't expect matlab hyperreflexia or clonus in this kind of patients. Neither you expect plantar extensor at the time of presentation, right? So at the
Yes, sir.
time of presentation, if there is plantar extensor or if there is hyperreflexia or clonus, then it goes against the diagnosis of GBS. Good. Then
If there is very rapid progression, like within 24 hours.
that can be there. Motor weakness can be there. But the other way around, if there is rapid progression of sensory symptoms without involvement of motor symptoms, then again it goes against the diagnosis of GBS, because GBS is predominantly motor. Though we may have sensory wala this one component, but it's predominantly motor. So if there is rapid onset and progression of sensory symptoms without involvement of motor symptoms, then it goes against diagnosis of GBS. More importantly, at the time of presentation, fever and constitutional symptoms are usually not there. That also helps to diagnose, exclude GBS.
Yes.
Got it?
Yes.
So how do you differentiate it from motor neuron disease? Say, you mentioned that point. Motor neuron disease versus GBS.
Yes. Sir, in GBS, sir, there will be flaccid paralysis with muscle wasting will be there, and there will be wasting of muscles as well as the deep tendon reflexes will be absent, and there will be the superficial will may be or may not be intact. The urinary bowel and bladder will not be involved, and
ठीक है, good. But
in
remember,
upper motor, sir,
very
there.
easy way of differentiating with motor neuron disease is motor neuron disease will have hyperreflexia, will have clonus, will
Yes,
have plantar extensor, will have fasciculations.
yes,
Correct now?
yes, sir, with clasp knife spasticity.
And how do you differentiate it from myasthenia gravis?
Sir, in myasthenia, there will be a diurnal variation with the symptoms more towards the evening hours, and there will be more of the ophthalmoplegia. The ocular symptoms are more pronounced, and
Most important, in myasthenia gravis, there is no loss of deep tendon reflexes. The
yes,
DTRs are very well intact.
yes,
Number one. Number two, muscle atrophy never takes place in myasthenia gravis. But because of the flaccid paralysis in GBS, in later stages, there may be muscle atrophies.
yes,
And number three, in myasthenia gravis, muscle pain never takes place. Patient will never complain of muscle pain. In GBS, muscle pain is a very common finding.
yes.
Got it? Other examiners, please proceed. We'll keep on continuing.
Dr. Payal ma'am.
Dr. Pragati, so what are the other diagnostic modalities, like electrophysiologic diagnostic modalities for GB syndrome? Dr. Pragati?
Yes, ma'am.
Yeah.
Ma'am, there will be nerve conduction studies we can conduct,
Mhm.
in which there will be prolong in demyelinating type. There will be in decreased conduction velocity with prolonged motor latency, and even the peripheral nerve F wave latency will be increased in the demyelinating type. Whereas in acute motor axonal type, there will be no features of demyelination. There the distal compound motor action potential will be less than 80% in the acute motor axonal type. And we can also do MRI spine to rule out any high cervical lesion. And in the MRI spine, it will be contrast enhancement of the nerve roots, which may be seen in GBS. And we can do stool culture for Campylobacter and Mycoplasma antibodies, as well as screen for infection with PCR, and we can do lung function test.
Okay, Dr. Pragati, when you mentioned about the subtypes of GB syndrome, can you please name the antibodies which are related with which subtypes? Typical antiganglioside antibodies and their relationship with the subtypes of GB syndrome.
Yes, ma'am. Ma'am, in acute inflammatory demyelinating polyneuropathy, there is no ganglioside which we can found, no IgG antibodies. Whereas in acute motor axonal neuropathy, that is MAN variant, there is GM1 and GD1A IgG antibodies. Whereas in AMSAN, there is GM1 and GD1A IgG antibody. Whereas in Miller-Fisher, it is GQ1B and GT1A.
Okay. And next question for Dr. Pragati. What are the complications that you expect in a patient of GB syndrome?
Yes. Ma'am, the patient may land up in respiratory failure requiring ventilatory support. Then the patient may have, due to autonomic dysfunction, may have cardiovascular stability, and the patient, because the patient will have a long stay in the ICU, it will require thromboembolism prophylaxis, and as the patient may have bulbar palsy, NG feeding, nasogastric feeding will be required, and the patient, if as there will be pain, neuropathic pain. So for pain component, we can consider gabapentin or amitriptyline. Eye care is important as there is bulbar weakness. Then patient may require cognitive as well as psychological support. And as GBS patient have long-term disability, so early rehabilitation we can do.
Okay, so muscle atrophy, compression, neuropathy, limb contractures, all these are the delayed complications of the GB syndrome, right? And also you have to take care of the nutritional status of the patient as well. Now, what are the management modalities of GB syndrome? Specific
Ma'am,
management modalities, if any, of GB syndrome.
Ma'am, immunotherapy, we can either go with plasma exchange or immunoglobulin, which are the first line
Which one
options.
is better? Which one is better?
Ma'am, intravenous immunoglobulin is more is better, but both have equal outcomes.
So if both are having equal
Ma'am,
outcomes, so why are you telling that one is better than the other?
fewer side effects with intravenous immunoglobulin
What is the other one? Other modality?
is plasma exchange. Ma'am.
Okay. Can you please elaborate on plasma exchange? How do
Yes,
you
ma'am.
do? Yeah.
Yes, ma'am. Firstly, when the patient firstly present within the first 4 weeks of the onset of GBS, who are unable to walk unaided, we can go for 5 plasma exchange of 50 ml per kg, that is 2 to 3 liters for over 2 weeks. As a replacement fluid, we can use albumin or FFP. Whereas in intravenous immunoglobulin, we can go with zero point 0.4 gram per kg per day of 5 doses over 5 days. And alternatively, we can also give as 2 gram per kg, which 1 gram per kg per day.
Okay. So what are the contraindications of IV immunoglobulin therapy? This is the first question. The second question is, can you combine IV immunoglobulin therapy with plasma exchange therapy for better result?
Ma'am, the newer zipper method goes with both, like plasma exchange and intravenous immunoglobulin, but it is under study, ma'am. Generally, we go for first plasma exchange and continue for 5 cycles, and then if it doesn't respond, then we go for intravenous IV.
Okay. What are the contraindications of IVIG?
Yes, ma'am.
Hello?
Ma'am, if there is any history of anaphylaxis or allergic reaction,
Okay. What else? Are you aware of any other contraindications?
ma'am, if IgA deficiency is there,
Yes, yes. IgA deficiency is a contraindication of IVIG. You were mentioning about complications of plasmapheresis. Can you elaborate? What sort of complications occur with plasmapheresis? Dr.
ma'am,
Pragati?
allergic
Yeah,
reaction,
yeah, yeah.
anaphylaxis, hypotension, chest pain, then any, ma'am, mainly the anaphylaxis and. That's all I know. Mainly, ma'am, we use FFP and albumin, which can trigger an allergic reaction in plasmapheresis.
Okay, allergic reaction is one complication. What else? What are the other complications of plasmapheresis? You had mentioned about hypotension and
Yes,
hypovolemia. Agreed.
yes.
So, what else? Any
When,
electrolyte imbalances?
yes, ma'am. It can also cause infection at the catheter site.
Yeah, so anything and everything, every invasive procedure is associated definitely with the risk of infection, right, Dr. Pragati? So, any electrolyte imbalances associated with plasmapheresis? Are you aware?
No.
Okay. So need to read it in details about plasmapheresis, right? Okay. So yes, there can be hypocalcemia, hypomagnesemia. Okay, because you are using citrate anticoagulants no, in plasmapheresis then. And there can also be hypokalemia. Amongst the other complications, there can be some bleeding or clotting related problems, as well as transfusion reactions or hypothermias. Okay. Dr. Shrikant, Dr. Ankur, any questions from your end, please?
Just two, one, two, three questions. No? How will
Yeah.
you assess the response? Suppose you have given IVH, whatever your choice, IVH or Plex, plasmapheresis, depending on availability or your choice, you have given some one treatment. Then how will you assess the response?
We can check Erasmus GBS outcome scale at 2 week after the admission.
So basically, you have to wait for 2 weeks because
Uh,
usually either IVIG or plasmapheresis there is slow response. It usually take to 1 to 2 weeks for response. So if after 2 weeks you did not get any benefit, suppose your power in this patient the power was better, 4 by 5. Suppose your patient was power was 2 by 5 or 1 by 5 in all four limbs. Patient intubated due to respiratory failure, got intubated, started on IVIG, and you waited for 2 weeks, and still there is no improvement in power. Then what you will do?
Sir, if the patient was on plasma exchange, then we can move forward with IV immunoglobulin for 4 weeks and then assess for any improvement.
If plasma fresh, then we can go for IVIG. If he was on IVIG, then
Sometimes there will be treatment related fluctuations, so we can repeat with the same same modality of treatment.
is there any recommendation to repeat?
No, sir.
Basically, clinically, you can wait for 2 to 4 weeks maximum, or we can. There is no clinical clear-cut recommendation, but your practice is need to repeat half dose of IVIG over 2 days.
Yes.
Okay, and but combining the both the therapy, there is no benefit because IVIG followed by plasmapheresis you cannot go because whatever IVIG you have given in plasmapheresis that will be removed. Okay, and
Yes.
plasmapheresis followed by IVIG, there is no clear-cut advantage. So you can repeat the same modality with half dose after at least after 2 weeks. Ankur sir, anything to add?
One question from my end for Dr. Pragati. Can we use corticosteroids? Bolus dose of corticosteroids, is there any role in management of GB syndrome?
No, ma'am, there is no role of corticosteroid.
And why is it so? What is the reason that steroid as immunosuppressant doesn't work as a management protocol in GB syndrome? Dr. Pragati?
Yes, ma'am.
Yeah.
It has not shown any effect in the recovery and the long-term outcome of
Yeah, absolutely. The reason behind that is steroids basically inhibit the clearance of the myelin debris by inhibiting the macrophages. Okay. And so the remyelination is actually hampered, and also the denervated muscle fibers, the damage to those denervated muscle fibers becomes aggravated with the use of the corticosteroids. Okay. So, are you aware of any novel therapies or newer modalities for the management of GB syndrome?
Yes, ma'am. The newer drugs such as isolizumab has been used in certain trials, but there is no efficacy when compared to IVIG. And
Okay.
the newer stem cells therapy are also coming up, whereas newer therapies which are targeting on the antibody complement pathways and inflammatory cells are
Right. Mhm. And also interferon beta A, brain derived neurotrophic factor, T cell cytokine inhibitors, but all these are actually experimental. No one has yet shown any definitive or finite benefit in the management of the GB syndrome cases. Ankur sir, are there any questions from your end?
No, I think
Shrikant, Dr. Shrikant?
most of
No,
the
I
things
think
have been
we can
discussed.
conclude with permission of Dr. Deepak. Deepak sir?
I just want to conclude with
Yes,
one
sir,
thing.
yes, sir, please.
Most of the things have been discussed very well. I hope it's not only for Pragati, it's a learning lesson for all of us. We all must have taken some important take home messages from this session. But for everyone, uh, when the patient is under your uh, admission, when the patient is relatively stable, we have a tendency to see the patient at times because we may have 15 patients in the ICU, may have 20. So we have the tendency of just looking at the monitor, looking at SpO2 99 hai, badhiya hai. Blood pressure is okay, fine. This doesn't happen with GBS as well as myasthenia gravis. Please don't trust SpO2. SpO2 is not just single one thing. It's a late predictor of respiratory weakness in both myasthenia gravis as well as GBS. Keep doing the respiratory examination, bedside examination time to time. If you find fatigueness in the patient, increasing fatigueness, increasing tachypnea, autonomic disturbances, it's time to early intubate the patient instead of delaying it and making the patient aspirate. So early extubation and immediate onset of treatment. For example, in myasthenia, you will be rapidly going with corticosteroids and uh, anticholinesterase. In GBS, straight away intubate. Delaying the intubation would be deleterious. Better early intubate, put on plasma plex or IVIG, whatever you have, and then already things have been discussed. My only thing is don't just rely on SpO2. You have many other parameters to decide the things. Look for ABGs, serial ABGs, and bedside examinations again and again. I think
PO2,
Absolutely agreed, sir. Deepak sir, any questions or any comments from your
Yeah,
end?
ma'am. Agree with Ankur sir. He has beautifully summarized. So in today's era, when we have a lot of gadgets available at our bedside, we can use a micro RPM respiratory manometer. It can help us in counting the forced vital capacity, negative inspiratory pressure, and at change of every duty or shift at 8 or 12th hourly, we can like after with the help of clinical assessment, we can use the device to see how the patient is improving. So this can help us in predicting the respiratory failure at a very early stage because these patients will show rise in PCO2 or drop in PO2 at a very later stage because it is a muscular
almost period
disorder.
status.
Yeah, these
Hypoxia
patients
or
don't.
Absolutely.
hypercapnia is
Yeah,
almost period status.
right. And these patients don't show any signs of respiratory distress. So with help of use of this micro respiratory RPM, we can detect the failure at an early stage. Secondly, with help of a focus, USG is readily available nowadays in our ICU. So we should daily screen the diaphragmatic thickness, diaphragmatic excursions, the diaphragmatic thickness. So this can lead to a lot of changes. We can see how the patient is progressing. Even when we are giving therapies like plasma exchange, IVIG, Diaphragm can help us guiding how we are going, whether we are progressing or not progressing, how the muscle are acting. So this can play a very game changer role.
Agreed, sir. Dr. Shrikant. Yeah.
I'm
Comments
done,
from
ma'am.
your end, please.
I'm done, ma'am. Thank you, Dr. Pragati, for revising the topic for us.
Yeah. Yeah, Dr. Pragati, it was a very nice presentation, but whatever points Dr. Ankur sir has mentioned, please take note of that. And the case which you have prepared possibly would have been a little bit better if you would have added the course of stay in the hospital and the therapies which had been utilized in treating this patient. So, yes, then, Ankur sir?
Yeah, just
Anything furthermore?
yeah, I would just like to congratulate Pragati. So it's not easy to come up, present a case in a public platform. See, all are seeing.
Absolutely.
It's
And
one of
grilled by 4 examiners.
one of 25, one of 30 guys will be ready to come forward in such case presentations. She has come forward and she has beautifully answered many questions. Almost all questions she has answered. So
Almost.
big round of
Agreed.
applause for Pragati. We congratulate you.
Thank you so much, sir.
And all the best for your upcoming examination, Dr. Pragati. That you whatever the answers you have given, they were more or less 100 upon 100. So very nice, and all the best for your upcoming exam.
Thank you, ma'am.
So,
Much,
okay.
sir, and ma'am. It was very informative for me also, ma'am. It was a revision as well as I got to know what all was I missing.
Okay. So, any other participants, do you have any questions? I think we have more or less covered the nitty-gritties of the topic.
Yeah, we
And
have covered, and I think we will exceed the time as well. So I think most of
yeah,
the things have been discussed. I'm happy to meet Dr. Deepak sir. I'm happy to meet Payel madam. We are very close to. I'm close to Shrikant. I know Shrikant very well.
okay.
Meeting you
Yeah.
all. Yeah.
Same here. I am happy to meet you all guys. Dr. Shrikant, I have met in some conferences, but
Yes, ma'am.
Dr. Ankur sir, Dr. Ankur sir and Dr. Deepak, I have not met personally. So it was nice meeting you guys. Thank you. And we can further conduct many more sessions online or in Zoom platform.
Uh,
Okay.
Sure, ma'am, sure.
Fatma, thank you.
yes,
So
ma'am.
shall we close the session then?
Yes, ma'am, we shall conclude it. It was
Okay.
actually a very nice session. Thank you, Shrikant sir. Thank you, Deepak sir, Ankur sir, and Payal ma'am. Thank you for being with us and sharing your knowledge with all of the students present. And we are looking forward to invite you more in these sessions. Thank you.
Okay.
Thank you.
And one more thing, Fatma, it is for you. If any of the participants have got any further questions, you may please send it to us in our email. We would be happy to answer those questions.
Sure, sure. That is very nice. Thank you, ma'am.
Okay. Thank you.